So we are really lucky to be having this conversation, and it's a really timely one as we examine where we are in this constantly evolving pandemic. What do we know today, and importance of today, since the pandemic is evolving and changing as we speak, as well as our reaction to it, and importantly, the role of states and what can we collectively, individually, as communities, as policymakers, do to really respond to the pandemic. And I want to start, Leana, by sort of framing a little bit of sort of where we are, but by paraphrasing a piece in the Washington Post that you wrote recently in July, where in that piece you talked about how many deaths there would be in the time it took to read your op-ed. And so in the hour that it's going to take us, or that we are going to spend together today, according to the latest CDC data, there will be in this next hour 1,600 new cases of COVID reported and 23 deaths in the United States. So that just puts sort of, I think, a really important sort of grounding heft and weight of what the pandemic is doing to our country and our loved ones. And we also know that the pandemic is not just devastating individuals and families and some entire communities, but it's putting incredible strains on our economy, and it has also exposed some deep structural challenges in our nation and some weaknesses in our healthcare system. And I think that's going to come up throughout our conversation today, because we're going to cover quite a bit of the aspects sort of public health, the pandemic, the role of states. But don't worry, for our good audience here, we will save time for your questions. I have a number for Leana and for Dr. Wen. I'll sort of change between formal and informal. We're going to keep 20 minutes for your questions. So don't wait till the end to post them. We're going to be looking at them in the Q&A pod. Please don't post your questions in the chat, because there's probably going to be a lot of chat and it's hard to find the questions there. So post them in the Q&A pod. So with that, let me start with sort of just really, since we have a state audience, Leana, let's, reflect on state constitutions, and the 10th Amendment of the U.S. Constitution clearly suggests that states have a major role to assure the health of the public, and including responding to health threats. And we've seen this, in spades, so to speak, with this pandemic, not just on public health, but education, the economy, governance of states, all facets of life. So as you go across the country, because you have been speaking across the country, even if it's from your living room or whatever room you're in today, what should state level elected and appointed officials be doing or considering as they lead their states to address these issues, given where we are today?
Absolutely. Thank you very much, Lisa. It's great to join you. Thank you for facilitating the conversation. And I really appreciated the framing that you had at the beginning about where we are, because I think so often we get lost in these huge numbers when we're thinking about the fact that 5 million cases. I mean, it's hard to process numbers like this, and to think that, I was looking over some of our writings and our news coverage from back in January, when we were talking about single-digit, double-digit numbers of infections, and now how do you process the fact that there are 1,000 people a day dying? And I also just want to say I really appreciate the opportunity to be with all of you, even though I don't want to turn my camera around, because I'm actually in my toddler's bedroom. With the study/television studio is my toddler's room, and it's, I think, the times that we're all in, right? We're making things work as best as we can as working parents, and just how we are. But it's wonderful to join you all, because I think that at this time, and in a direct answer to your question, Lisa, that it is the officials on the state and local levels who are shouldering the huge responsibility of responding to the pandemic. And this is, by the way, not at all a political or partisan conversation, right? And not a partisan frame in this at all. Only to say that when we have seen many instances where the national leadership did not step up in the way that they have in other countries. And as a direct consequence of that, states and local leaders have had to step up themselves. And I think we've seen extraordinary work that state and local officials have done in these last several months. So if it's anything that I would want to convey, it's first of all, a big thank you, because you are they are absolutely instrumental. You're leading this effort every single day in very, very challenging circumstances. I mean, by far, I think the biggest public health catastrophe, biggest public health crisis of our lifetimes. But in the way of lessons, I would say first, clear, direct messaging is so critical. Conveying that, look, there are things that are changing, and change and constant evaluation and reevaluation is okay. Back in February, March, we didn't know, for example, about asymptomatic transmission. Now we know that 30 to 40% of cases of COVID-19 are transmitted by people who have no symptoms at the time that they're passing it on to others. We also didn't know at that time about aerosol transmission. We thought that just like if you have the flu, that it's people coughing and sneezing and they're transmitting that way. We didn't know about transmission of the virus just by breathing and speaking. And so at that time, we were not recommending masks, but the recommendation of masks has changed as a result of new evidence and information. So I think conveying what we know, what we don't know, conveying that constant reevaluation is the bedrock of emergency response is really critical. And I think also another element critical in the communication is about letting public health lead in the response and not pitting public health as somehow the enemy. And I am really concerned about this because so much of the rhetoric has been focused on public health versus the economy, public health versus schools, seeing it as somehow this false dichotomy, this choice that you have to make between people having their jobs or doing what's best for public health, or students going to school or doing what's best for public health, when actually, when we look at the examples of other countries, we can see that public health is the roadmap to the economy reopening. Public health is the roadmap to schools being up and running. And so I hope that that's a message that we can all convey and to continue to follow the science and the evidence in our decision making.
Yeah, no, really great points about the clarity of communication. I think the role of leaders, this is really a time where that constant open communication, and the point you made, Dr. Wen, about this is what we know today and here's what we don't know. And so often I think the public wants to hear certainties, and I think we've been learning over the last 6 months that we're all having to manage uncertainty, and therefore transparency from leaders is critical. I think that's a really important point. And also this false dichotomy, I would really emphasize that. And so as we look forward to the days ahead, some important things are sort of on the calendar for the days and weeks ahead. So the first coming up is sort of Labor Day. We saw with Memorial Day and the July 4th holiday, we had large gatherings. I think we've all seen various videos of, incredible numbers of unmasked people closely together. Do you think we're going to see a Labor Day spike? And if so, what do you think elected leaders can or should do or think about? Again, we're just here to provide reflection. And I'd just be interested in your thoughts about sort of the Labor Day spike. And then I want to turn to the issue of schools that you just alluded to, because we've already had some questions about schools in the Q&A, and that's a lot of the topic of conversation today. So the issue of the Labor Day spike, are we worried about that?
Yeah, it's a great question. And I mean, let me maybe back up for a moment. Back in May, I wrote an article for the Post about the idea of us moving to a position of harm reduction, which is something that we in public health know very well, because the idea is that if you're going to be engaging in some kind of behavior that's maybe not the most helpful, we at least should be doing our best to reduce the harm of that behavior. And so in public health, you might think about motorcycle riding and helmet laws. You may think about needle exchange and naloxone for people with opioid overdose, right? That ideally, we may not want people to be engaging in these behaviors, but if they are going to be anyway, we should be doing our best to reduce that risk. And actually, that's what I think was where we are when it comes to COVID-19.
Yeah.
There is so much community transmission that's happening all around the country. There's no way of getting to zero risk unless we went to a shutdown once again, which is not something I think that many of us, that I'm sure it's not something that none of us would want, but I think many of us would find to be politically not feasible. And so quarantine fatigue is very real. Yeah. And I think that it's very difficult for all of you, for all of us as public health experts, officials, et cetera, to be telling people, well, just don't go out and see people at all. I mean, that's just not feasible. But I think that now, especially given what we know about COVID-19, there are ways for us to advise people on doing what they want to be doing, but in the safest way possible. So for example, we should be advising people, especially when the weather is nice, to be outdoors. Being outdoors versus indoors reduces risk of transmission by 18 to 19 times, which is so critical. And so if you're going to be seeing friends or loved ones, get together outdoors and not indoors. Really critical to emphasize that the majority of infections and outbreaks that we've seen are with people who are gathering with their loved ones. That's right. Yes, these super spreader events are real, of the choirs and people going to big rallies and other things. And I'm not saying we should have those gatherings either. I'm just saying that people often don't think about their loved ones as being, they think about, well, friends and family, it's safe. That's my extended family. When actually that's where we're seeing the infections really come about. So think about length of exposure, that maybe it's fine to people come into your house if they have to use the restroom, but don't have a dinner party, because the length of exposure of having dinner for several hours with someone in your house, that's going to lead to harm. And so I think we can really be just targeted in our interventions. We can also advise, for example, about cumulative risk, that just because you're now going to the doctor's office and to your dentist doesn't mean that you now also have to go get your haircut and go to the gym. That you can think about reducing your risk in different ways. And I would also really urge our state officials to think about this in the way that we think about budgets. I wrote about this also, the idea of having a coronavirus budget. We think about city budgets, right, or state budgets all the time. That's just the work that we do as well, I guess as people, but definitely we think about budgets. Well, we know that there's no such thing as a limitless budget. You can't have everything. And so in the state budget, you might have, education, policing, health, all the other things, housing, parks. You can't fund everything to the fullest extent. So think about a coronavirus budget the same way. So if it is essential for our schools to be back, what are you willing to give up? Are we willing to say, let's restrict restaurants, let's not have indoor bars, let's not have nightclubs, because we, at this time of coronavirus, we can't do it all. And so what are the things that are the most essential? And what are the things that you're willing to give up in order to allow those things to happen?
No, I read that piece about the budget, and I thought it was a great framing, because, and especially for a leader in a state. And I think what it also brings up is the important thing that it's not one size fits all. And that's very much the case with COVID, because it's taking into account what are community transmission rates, are the trends going up, are they coming down, what rate of testing, there are all these variables. And we heard last week at our conference from Mandy Cohen in North Carolina, and just really, making sure that you're keeping which indicators you're tracking, and you're tracking those faithfully. So I want to, as some people say, double click on the issue of schools, because like I mentioned, we got a question, and also because it's kind of personal for me, as I'm dropping off my twins back to 2 Ohio universities to this week and next to go back to school. So and school means lots of different things in this country. It's K through 12, it's colleges, 2-year, 4-year, a lot of different settings. So, again, there's variety there. But as you recently wrote, in fact, yesterday you wrote about this, that, clearly children do get infected, and kids over the age of 10 are, from what we know today, as infectious as adults. And there have been quite a few cases of pediatric cases. So, as you think about the situation with schools, we've already seen what happened in Georgia with, some schools reopening with, spread pretty quickly and isolations. And, in other countries, as you've alluded to earlier, schools have been able to reopen and they've been pretty good. So what else, as we talk to, for this conversation with these leaders, what's the difference between elementary school and high school as we're learning about the different risks at different age groups because of behaviors? There was an article in the New York Times, I think today or yesterday, by a colleague of mine, Naomi Bardak, also a pediatrician, about, that actually we're learning that quite a bit of transmission in schools is the adults, and, and they're getting it from the community, bringing it back. So it's complicated, but given where we are today, Dr. Wen, what would you recommend to our audience to think about as they consider, whether they should reopen, when they should reopen?
Yeah, this is such a complicated topic, and I'll just say first off, to recognize that complexity. I understand the arguments from all sides of this, right? I'm a mom of two little kids. My son has been out of preschool and it's kind of driving all of us nuts. He's in his three-nager phase, which is a term that I didn't understand until it happened. But anyway, different story. I also, I oversaw school health in Baltimore for our 180 schools and really understand how, 80% of the students that I served qualified for free or reduced lunch. They depended on schools for obviously cognitive development, but also food. School is the place of where they were safe. So many of our kids now have this big digital divide. There is this real COVID slide that's also happening as a result of the educational disparities that are ongoing. So I really understand the importance of in-person schooling and why that needs to occur. On the other hand, I also know that it is just not possible to reopen schools in communities where there is active surge. When we think about it from simple math, if you have a community where where 1 in 100 people have COVID-19, and you have a school of 1,000 people, on day one you're going to walk in and there are 10 people who are actively infecting others. That we've already seen occur in some of the schools that have reopened, that we've already seen cases where the schools had to shut down rapidly, or hundreds of people, I believe more than 200 people in a particular school district in Georgia, in suburban Georgia, had to be out on quarantine immediately. And you compound that with the issues that we're having in testing. What happens if you can't get a test back for 7 days or 10 days? Then you have, let's say one student has a fever. That student is going to be out, but while awaiting those test results for 7 or 10 days, do you quarantine the entire class? What about all the parents of the students in the class? What about them? What about the teachers? What about their kids? Do they also stay home from school? It soon becomes a really challenging problem to be able to resolve. And so I think that looking at where we are in the country, I think there are some places where there is such active community spread right now that it would be very difficult for schools to reopen and to stay open. Yeah. Then on the other hand, we also have places around the country where the community spread is pretty low, where testing is widely available. So you know that because the test positivity rate is low, you know that you're actually getting an accurate count of what the tests of the people who are getting infected and who's not getting infected. So those places can reopen with some safeguards, with many safeguards that the CDC has outlined. Then I would say there is this huge gray zone for the rest of the country that I think really need to consider how they can, as the single most important thing, how they can suppress the level of community infection. Because if they're able to do that, then they at least have some chance of reopening. Yeah. Now, Lisa, I want to address the question that you raised about age and to highlight what we don't know. So here's what we do know about kids and COVID-19. We do know that kids get sick. There was an excellent report done by the American Academy of Pediatrics and Children's Hospital Association that found that so far in the pandemic, and they were looking until the end of July, that 338,000 kids have become infected with COVID-19, and that's of the cases that we are doing testing for. There are potentially many others that we're not testing for that we don't know. We also then know that 90% of those infections occurred in the last month again, not surprising given that community surge has been ongoing and we've had better testing in the last month or so, but that's a lot of kids getting sick. 97,000 kids got diagnosed in the last 2 weeks of July alone. Consider if these 97,000 kids were all in school at that time, how many outbreaks that we could potentially be dealing with. So we do know that kids get infected. We do know that kids get sick, although at a much lower rate than adults do. Kids can get sick. They can get this rare but very serious multi-system inflammatory condition that could result in a toxic shock-like syndrome and multi-organ damage in children. So rare but very serious ailment. When we look at transmission among different ages, the jury is out. So there was a very large South Korean study, large South Korean study that was done that traced the contacts of nearly 60,000 people. And they found that kids 10 and older are just as likely, if not more likely, to transmit COVID-19 than adults. Their finding was that kids under 10 were less likely to transmit COVID-19. But when you look at these statistics or the results more closely, they only traced 57 kids under the age of 10. So so while their results are statistically significant, we're still looking at a pretty small sample. We have some other examples that may point to the opposite. There was another study done that found that kids under 5 actually carry 10 to 100 times the amount of virus in their nasal passage than older people do.
Right.
And we also have some examples of transmission among younger kids. In the case of a Georgia summer camp, they found that 8 kids ages 6 to 10 in the summer camp, where there was a big super spreader event, more than half of the kids ages 6 to 10 got infected, as well as, by the way, more than half of the staff. Lisa, to your point about adults and older people, older people who are not kids also potentially getting infected too. We know that in the case of Israel, that after schools reopened, that there were many kind of these larger outbreaks, such that nearly half of the infections in the country can now be traced back to schools in some way. And so I think you counterbalance that with the examples of daycare centers in the US that opened for essential workers where you did not have outbreaks, and other countries that reopened and did not have outbreaks in their schools. But note that in these other countries, they did not have active community transmission. Right. All this is to say, we just don't know. But we do know that kids will spread COVID-19 to some degree, probably comparable to adults, but we don't know exactly how much and how it differs among different age groups.
Yeah, it's so there's a specific question. I'll take it now because we're talking about schools, and it's complicated. I don't want to minimize the complexity that the leaders on this call are facing, but the question is specifically, are there any specific policies that you feel state governments ought to implement to mitigate transmission in school environments, like a maximum class size, the provision of a specific kind of mask, an N95 or other medical resources or personnel, immediate contact tracing, et cetera? Anything that's bubbling up, and there are a number of different websites I know that folks are working on in terms of reopening schools safely, and the American College Health Association has put some out for colleges, et cetera. But anything you would like to mention briefly here before we move on to some other questions?
Yeah, so I think the CDC guidelines as a whole are very helpful. I don't think that they are as explicit enough. I can tell you as a former local official, I would have loved to see something like, here are the 20 things that you must do. Here are the 40 things that are nice to have. Here are the things that there's limited evidence. I mean, I would have just loved to see a list like that, because you don't have time as a local official, and you also need the cover of the national public health experts. So we don't have quite that level of directive detail that I think would have been really useful. But I do think here are some general concepts. One is de-densify. We know this is a disease that spreads from person to person. So the fewer people you can have in school, the better. And another way to think about this is, who are the most essential to be in school? Younger kids, kids with special needs, they can't learn necessarily as well as those who are high schoolers who can learn via virtual. So one way is to de-densify by having only kids who really need the schools to be there, or to also, a lot of people have been doing these hybrid modules of spreading out the day. That's another way of de-densifying that's really important. Another concept critical is the idea of cohorts. Instead of having all the kids associate with everyone in a school, if you divide them into cohorts or pods, that way, if there's an outbreak, you don't need to shut down the entire school. You could just ask these 20 people or 30 people in a pod or a cohort to be able to shut down, or to be able to go home. I think also making sure that virtual learning is an option, and so that we are protecting the health and well-being of those who really cannot be in school for whatever reason, whether they're students or teachers, is going to be really important. Mask wearing, having requirement for a mask is so important. Don't do the N95. The N95, as someone who has worn them for a long time and still wear them in my medical work, it's extremely uncomfortable. Even to do a procedure for an hour in N95 is very uncomfortable. You can't do that for the whole day. A lot of people wear the kind of mask that they are the most comfortable with, but require masks. I know it's not comfortable, but it's something that we can do that definitely reduces the rate of transmission. Some studies have shown by at least 5 times. And if that's the sacrifice that we have to make in order for schools to come back, that's really important. So I think that those are the kind of the things that I would say are the most important, although certainly there are many other aspects of the guidelines like cleaning and sanitation that are important too.
Great. No, I de-densify. That's a really good point. So I want to turn now to, again, sort of future oriented, and we're coming up on the 2020 election, and there are a number of governors who are up for re-election or election, and many seats in state legislatures. And are you seeing candidates talking about their platforms and the pandemic? What would you like, what would you suggest that they take on in their platforms?
That's really interesting. I mean, I think that on the national level, I definitely would be looking for what specific steps we should be taking. Actually, I would say on the local state levels too, I would be looking for what are the specific things that we should be doing short term, medium term, and long term, because they're different. I think that short term, we should be looking at what are the urgent things, for example, around data collection. Without data, without better testing, we're flying blind. Can we build better, even something as basic as a dashboard that's in real time to be able to track testing? What percentage of tests are coming back within 48 hours? Who's being tested? Are we targeting the right demographics? Are we making sure that we're not just testing white communities and privileged communities, but we're also addressing racial disparities when it comes to testing and diagnosis and treatment? Then I would also be looking at medium term. What is our strategy for containing COVID-19? Do we have a plan for closing, for example, the indoor bars and restaurants for the short term so that we can have schools be open? How are we addressing this? Then long term, how are we thinking about the investment, not just in healthcare, but in public health? And what are we know that, for example, that health is tied to so many other factors, including housing, food, other things. How are we thinking about this during this time of pandemic as well?
No, those are great points, and you brought up two things I just wanted to comment on. One is the issue of availability of testing, and I know that there's been some discussion around some of the ethics of testing, particularly for cities where there are large universities. Because if the universities are testing aggressively, and many of them have more resources, then that is, with some communities having testing being over, 2 weeks delay, not enough testing, this sort of ethical issue of testing resources in the community being sort of swamped by the university versus the community. So I think that's another factor that, it's all connected. The testing resources are not just for one sector, they're for everyone. And then the other important one that you brought up is the issue of disparities. And that's been really in stark relief as we see, more persons of color who are essential workers who don't have the option of staying home and who have to continue to work, and the impact of the economy. So I didn't know, as we think about in public health, we always think of the health of the public and all communities. And what do you think elected leaders and state officials could be doing to really tackle the COVID-related disparities that really uncover longstanding inequities in care and health in our nation?
Yeah, so these are such great questions. The first issue, I might address a little bit differently, if I may, because I
Please.
think there has been a lot of discussion about this when it comes to not only universities, but also the MBA, and other, we would say wealthier, right, institutions. And there's this talk about, well, are they just hogging all the tests and not leaving enough for everybody else? I actually think that we can, in this case, I think there's a different approach. I think that we need to be separating testing into testing for people who are higher risk and screening testing for people
Okay.
who have low risk.
Right.
And what I mean by this is I think right now we have kind of mixed it all up and we're just calling it a test. And as a result, people are not getting the right test. People are confused about what test to get. And people are, and that's creating a really long backlog of testing. A test is worthless if you're not getting the test back within 48 hours. And so there is another way around this. What I'm a proponent for is the widespread, cheap, rapid antigen test. That test has lower accuracy. It's not as accurate as the PCR molecular test, which is what we have right now.
Right. And we
But
just
I
saw
think
that with Governor DeWine. The cheap rapid test came back positive. The PCR test came back negative. So yeah, it's definitely not as accurate. But
and by the way, that was a kind of an anomaly because both tests have a pretty low false positive, meaning that if you test positive, you really should be positive. So I don't know what happened there exactly, but I think that the most important is that the antigen test does have a higher false negative rate, but you can counterbalance that by thinking about it as screening, which is what we do in medicine all the time. If you have heart disease, the most accurate test, if you will, is a catheterization to look at your arteries. You don't do that for anyone just to screen to see whether they have heart disease. You don't ask somebody to go for this medical procedure. There are much less invasive, cheaper ways of doing that particular test. Maybe this is too much of a very specific medical analogy, but I think you see my point that we do this in medicine all the time, that people with low risk, for example, college students coming back, NBA players who are trying to decide whether to play, they don't have symptoms, they don't have exposure. They're just trying to figure out, can they go into work? Can they go into school? You do the screening test for that. And then you save the more accurate test for those who have symptoms or have real exposure. And I think that's a way around this particular question of how to ensure that we get the right testing to the right people. I do think that this issue of disparities is a much broader one. And I think here, there are both short-term and longer-term solutions too. I testified to Congress twice about this, and specifically, I did talk about how longer-term we need to talk about structural racism. We need to look at health insurance. There are longer-term, whether health insurance should be tied to employment with tens of millions of people out of work. There are longer-term issues that we should be addressing, but shorter-term, there are very specific things that we can do. For example, looking at the fact that isolation and quarantine ends up being a privilege that not everybody has. What if you live in multi-generational crowded housing and your work, you think you might get fired if you don't go in? Then you don't have an incentive to isolate and quarantine yourself if you're exposed or if you have the illness. State and local governments can set up these isolation quarantine facilities free of charge, converting unused dormitories or hotels for this purpose, right? That's something short-term that we can do. Or when it comes back to testing and demographics, don't just have drive-through testing. There are people who can't drive to a particular location. Look at where your testing sites are. And if they're not, they should be in communities, wherever it is that people are. Those are, again, some of the kind of basic things that we can do to make a difference.
That's great. No, really excellent points. And I just want to remind folks, we have, you can post your questions in the Q&A pod. We're answering them as we go. We have lots more to cover here. One of the questions that I want to sort of turn to is, you started with the importance of communication. And so you've worked with elected leaders, 2 mayors in the city of Baltimore and others. What are some of the, lessons you've learned along the way about working with elected leaders and office holders. And I want to put the added frame on this that you kind of alluded to, which is we're seeing a rash of public health leaders stepping down from their roles in states because it's just been, so challenging and exhausting and never ending, but also because they've been attacked, and public health has been sort of held up as the part of the challenge, part of the problem, as opposed to part of the solution. So what are your reflections as a public health leader about working with elected leaders to move us forward?
Yeah, I mean, I think that it's really hard because public health, there's a saying that that there's no face of public health, right? That by definition, we are effective when we are invisible, when we have prevented something from happening. And I think as a result, nowadays, when we appear, it seems to be giving bad news. And then all the problems, it's kind of like shooting the messenger, that you are really blaming the messenger for the problem. When of course, I think people know intuitively, they know that we in public health didn't cause coronavirus, but we still are the bearer of this bad message that we now can't go to school and work, etc. The other part about public health being invisible is that there is no face of it. And then it becomes the first thing on the chopping block because you don't see the impact of something that you worked to prevent. So public health departments are hugely under-resourced as it is, and now you're asking them to take on this additional responsibility that's all-consuming. So it really is challenging. So I would urge all of you to look at the public health budget and to see how an investment, often something that's a small investment in public health, really makes a big difference. I would also really urge you to, I'm sure you are already, but making sure that you're on the same, that everybody's seeing from the same playbook, or from the same songbook, because otherwise it becomes really confusing for the public to be able to understand. And I think that public health officials really need the cover that you as the state officials are providing right now as well, because otherwise they are being put out as the enemy, when I think everybody is trying to do the same thing and working and doing the right thing.
Yeah, no, it's a really important point. So we've been talking as if sort of COVID is the only thing we're facing, but the reality is that several states have already grappled with Hurricane Isaias that just came through, and I have a place in Florida now that we're looking at many more hurricanes, but there are going to be other crises, and the pandemic has had other sort of ripple effects. For example, we know as a pediatrician that folks aren't coming in, there's been a lot of delayed or foregone care. So immunization rates are going down in children for measles, mumps, rubella, etc. And so what would is there something policymakers at the state level can do to make sure that the care that still needs to be delivered, even as we grapple with the pandemic, is actually happening, so that we are not then faced with other crises, other pandemics?
Yeah, I really worry about this. And I also understand why it is that people are hesitant to seek care during this time. I'll just tell you personally that I gave birth during the pandemic. My baby was born on April 3rd. And, you can imagine that was a very harrowing time, as we were worried about hospitals being over capacity. We know now a lot more than we did before about transmission of the disease, but still a lot of anxiety around just seeking routine medical care during this time. I mean, I would urge, I think it's important for us to spread the word for all of us to, again, be on the same page about this, that hospitals now know so much more than they did about transmission of the disease and about protection. And so people should be getting their routine care. Whatever routine care they can get through telemedicine, still continue to do. If there are alternatives, continue to seek these alternatives, but you can't get vaccinations remotely. And that's something that I'm really worried about, that we're falling behind on routine childhood vaccinations. We're getting behind on mammograms and pap smears and other screening that, again, cannot be done remotely. And I think we should reassure people that they should get these routine care when they cannot do so remotely.
Yeah. And I think that also speaks to another set of data and evidence that's emerging of the the sort of collateral deaths, the excess deaths that are being estimated due to other conditions where care was not sought or for whatever reason. So we are seeing deaths not just from COVID infection and disease, but also from other conditions, and we're just learning about that. So the importance of seeking appropriate care even during the pandemic, I think, is really critical. And again, communication from the state is important here. We have another question here back to the school issue around, if there's any examples around the world of a successful reopening of a school without any testing of the children, because this individual is asking about a middle school that's reopening with no testing of the children.
Sorry,
I don't think schools are testing kids. It's the community is testing kids, right?
That's exactly right. I mean, I think that, there are, so not here in the US, Germany has a pilot where kids are tested every 2 to 3 days, I think it is,
Really?
at home, that they have a home test that they administer. And again, it would be one of these faster, not as accurate tests, but, even if it misses 20% of positives, you're getting 80%. Right now, we're getting 0% of the asymptomatic cases. There are some universities that are thinking about doing pilots like that as well. But to my knowledge, schools are not doing that right now in the US. Of course, if there are positive cases, those are identified, contact tracing is then done. But I think schools have also found that contact tracing, as we in public health know well, is very complicated.
Yeah, no, good point. Another question asks, do you think that the federal government can do anything that it's currently not doing to expedite the expansion of both forms of testing that you talked about, both the screening versus the expensive high-risk availability? Is there a role for large research universities here? Is it a lack of resources or lack of financial incentives for private sector entities that's preventing the expansion of testing, or is it something else? What's your sense?
Here's my view on this, and I think a lot of public health experts would agree that what we really need is the federal government to activate the Defense Production Act. Because we're talking about, and I think the frustrating thing is these supplies exist. Other countries are doing it.
Exactly.
It's not as if they have a secret patented technology that we don't have access to. We have, India and Senegal, as examples, have been able to manufacture these antigen tests for $1. They can do this, we can do it too. We have these rapid antigen tests approved already for use in the US, and so we can also do this. But we need to be able to produce this at the scale that we really need, and it should not just be individual universities negotiating with the company. We could do this so much better by having the federal government manufacture these tests by the hundreds of millions in a way that ensures that we don't run out of reagents, because that's what we have seen. We've seen serious supply chain issues where a chemical here runs out and then all the labs end up getting backed up. Then you have enough of that one chemical, but then swabs are out, or you have plenty of swabs, but then people don't have enough masks so that they can't administer these tests. And so there's a way around this. I think that states, in the absence of that kind of federal coordination, we've also seen states band together and use their collective purchasing power in this regard too. So I think this can be done, but ultimately this is a scale issue that really should be addressed at the federal level.
Yeah, and I'm glad you brought up those sort of cooperative purchasing power agreements across states, which raises a broader issue of collaboration between states. At Academy Health, we help to manage the Medicaid Medical Directors Network, where it's incredibly valuable to those Medicaid medical directors to learn from each other. So, have you seen more and more of this sort of cross-state collaboration? I'd just be interested in your thoughts on what it will take to sort of foster more of that, because we're all having to learn, as every single day, what is working and what worked yesterday may not work tomorrow.
That's a good question, and I believe that there are. I know that there are many conversations happening among the public health leaders. we all know each other. It's a small world. And so we definitely all talk. And those of us who are on the outside now are trying to assist to the best of our abilities. I know that governors through the NGA and through others are in contact as well. I do think that there are just fantastic examples of that type of collaboration and also of extraordinary initiative by local and state officials. I just wish that, again, there's better coordination. And again, not a political ideological statement, but rather just a wish on my part.
Yeah, exactly. And certainly in my years of working at the state level and helping, I cut my teeth. My first job was in a public health department. So definitely found that learning from my peers was incredibly valuable, because there's nothing like talking to somebody who's in your shoes, who understands exactly what trade-offs you're having to make, what resources you do or don't have access to really help inform your decision making, because there are often no easy answers. So let's turn to something we're all watching with anticipation, and that's the upcoming COVID vaccine. There's it's sort of a race, and we've certainly seen the recent announcements from Russia, but the question specifically is, how confident are you that clinical scrutiny of prospective COVID-19 vaccines will be sufficient to ensure safety in this country?
I mean, it's a difficult one, because I can't really imagine that I would be in a place where I'm even having to comment on this, right? Because we trust the FDA to be independent, to use the best available science and evidence to evaluate safety and efficacy are really critical. Safety, because you're giving this vaccine to otherwise healthy people.
Right.
And there actually is a potential risk. People will say, well, what's the risk anyway? There actually is a risk, because you're giving, in some case, versions of this virus or some platforms of this virus that could actually stimulate the immune system. And one of the risks is that it could make you have even more severe illness from COVID-19. You look at this syndrome, this rare syndrome in children, and what we believe is one of the effects of COVID-19 is that it overstimulates your immune system, and the negative consequence is actually because of your overactive immune system. We definitely don't want to make it worse for people, and we also want to make sure that it's effective, because otherwise you're giving people false reassurance. All this is to say, I think as long as we continue to use science and evidence and to not take shortcuts in the science, we'll be fine. But I hope that we do not put our scientists in a position where they have to succumb to political pressure.
Yeah. Well, I think that's a wonderful question and answer to end this webinar on. I want to take a moment to really acknowledge your leadership and your stepping up during this national crisis to really help inform the public in a very accessible and easy to understand way. I can't emphasize enough the importance of that communication as we all struggle to adjust to this life. I used to say when will we be post-COVID? Right now, I'm just saying this life with COVID, because I'm not sure when that post will be. But thank you to all our participants who joined us today, and thank you for the questions. And I see Wendell has joined us again, so maybe he wants to give us the official CSG sign-off.
Mute.
You're good now.
Okay, I think I'm unmuted. Thank you, Dr. Wen. Thank you so much, Dr. Simpson, for a great conversation, and for our participants for those not simple questions. Going forward, I just want to remind everybody that we did tape the session. It is available on our website. I encourage you to go to the website to register for those other webinars. And again, thank you so much, both of you, for the work that you're doing in the public health field. And I think we have a renewed interest and focus on public health. And I think your message, no doubt, got across to our members about why it's important if this pandemic hasn't already done that. So thank you really for your time. And thank you all again for participating. And that concludes our seminar.
Thank you.